So, good day to everyone. Let's continue with our discussion on depressive disorders. So far we have talked about two major disorders among the mood disorders, which is the major depressive disorder and the persistent depressive disorder, or previously called the dysthymic disorder. So today we're going to talk about the depressive disorders not otherwise specified. There are three. The first is minor depressive disorder, second, recurrent brief depressive disorder, and the premenstrual dysphoric disorder. So minor depressive disorder is, of course, the lighter version of the major depressive disorder, which may be as common as MDD, no, with around 5% prevalence rate. The diagnosis of the symptoms equal to the duration of those with MDD, but with less severity. No, so there has to be at least two, but less than five of the major depressive disorder symptoms. But the duration should also be 2 weeks. Course and prognosis is also like major depressive disorder, but has a long-term course that requires long-term treatment. Now, treatment is only through psychotherapy and pharmacotherapy combination. Now, another disorder is called recurrent brief depressive disorder, which is characterized by multiple, relatively brief episodes of depressive symptoms occurring at least once a month for 12 consecutive months. So, this is also a long but recurrent and brief. Depressive periods last at least 2 days but less than 2 weeks. Now, except for duration, criteria A of the major depressive disorders are met. So again, this time, uh, criteria A, meaning 5 of the 9 symptoms of depression, should be present. No? And the duration is at least 2 days but less than 2 weeks. Now, the other of the three is called the premenstrual dysphoric disorder, also known as the late luteal phase dysphoric disorder or the premenstrual syndrome, the PMS. This is actually a controversial a diagnosis. No, the syndrome involves mood symptoms, behavior symptoms, and physical symptoms. So there are three areas that are affected with your premenstrual dysphoric disorder. Now, the DSM-5 criteria for PMDD states that criterion A, in the majority of the menstrual cycles, at least 5 symptoms must be present in the final week before the onset of menses. They start to improve within a few days after the onset of the menses and become minimal or even absent in the weeks post menses. So, criterion B, one or more of the following symptoms must be present. Number one, marked affective lability, mood swings, feeling suddenly sad or tearful, or increased sensitivity to rejection. Number two, marked irritability or anger, or increased interpersonal conflicts. Number three, markedly depressed mood, feelings of hopelessness, or self deprecating thoughts. And number four, marked anxiety, tension, and or feelings of being keyed up or on edge. Now, criterion C, one or more of the following symptoms must additionally be present to reach a total of 5 symptoms when combined with symptoms from criterion B above. No? So number one, decreased interest in the usual activities, subjective difficulty in concentration, lethargy, easy fatigability or marked lack of energy. Number four, marked change in appetite, either overeating or specific food cravings. Number five, either hypersomnia or insomnia. Number six, a sense of being overwhelmed or out of control. Now, the physical symptoms such as breast tenderness or swelling, joint or muscle pain, a sensation of bloating or weight gain. Now, the symptoms, criterion D, the symptoms are associated with clinically significant distress or interference with work, school, usual social activities, or relationships with others. Criterion E, consider other psychiatric disorders. The disturbance is not merely an exacerbation of the symptoms of another disorder, such as major depressive disorder, panic disorder, persistent depressive disorder, or personality disorder, although it may co-occur with any of these disorders. Now, criterion F, criterion A should be confirmed by prospective daily ratings during at least 2 symptomatic cycles, although a provisional diagnosis may be made prior to this confirmation. Now, exclude other medical explanations. Criterion G, the symptoms are not attributable to the physiological effects of a substance or another medical condition. So PMDD, the course is chronic. They tend to be chronic. Treatment would be either progesterone supplementation, your SSRI fluoxetine, or your anxiolytic alprazolam. No, pharmacological treatment could be several. No, mostly we use the tricyclic, the serotonin-specific reuptake inhibitors, or the serotonergic noradrenergic reuptake inhibitors, or even ACT and psychotherapy. Now, what are the commonly used antidepressants that now in the market? And most of these are equally effective. No? Like we said, like our consultants in the past says, uh, antidepressants are all effective. They just differ from their side effect profile. No? So, for example, comparing the side effects of your old antidepressant meds, the tricyclic antidepressants, to the newer ones, the SSRIs and the SNRI, you will see that the tricyclics would have a lot of cardiac conduction anomalies, sedation, orthostatic hypotension, so which is difficult when you're giving this to an elderly person. Peripheral and central anticholinergic effects, so you would have your tremors, ataxia, etc. No? Now, with the newer antidepressant called the SSRIs or the SNRIs, the most common would be gastrointestinal upset, no? Nausea and vomiting, headache, and dizziness. These are the 3 most common. And I usually tell my patients when I see them and start them on antidepressant medications to watch out for these 3 and not to be alarmed, because they're usually transient and should be gone in a few days of continuous medication. Now, the serotonin specific reuptake inhibitors are the most widely prescribed drugs for depression. They have fewer side effects, and there are more rational prescribing and better patient compliance because of its better efficacy and less of its side effects. Now, the common side effects, although they're less, are nausea, decreased libido, and decreased sexual function. There's a low threat for overdose, so even if patients take a lot of this, there is less danger for its lethality in cases of overdose. So the most popular brands would be your fluoxetine, your sertraline, and your escitalopram. Now, how do these antidepressants work? No, we said in the previous lecture that depression is caused by a depletion of our biogenic amines, namely our serotonin, our norepinephrine, and our dopamine. So this is how it works. No, there's an increase in the amount of serotonin in the synapses by inhibiting the reuptake of the serotonin into the cells. No, so for example, in this particular diagram, you see that these presynaptic cells would have vesicles that contain serotonin. So when these vesicles eventually are released into the presynaptic cleft, there will be an increase of the serotonin levels in the cleft. Now, normally, the serotonins that are released by these vesicles are reuptaken back for recycle. Na? These are reuptaken by your reuptake transporter, which is regulated by your autoreceptors. Now, our antidepressant medications actually block these reuptake inhibitors, reuptake transporters and autoreceptor sites thereby inhibiting the reuptake of the serotonin back to the presynaptic cell, such a way that there is now flooding of serotonin in the cleft, attaching to the serotonin receptor sites on the opposite nerve cell, thereby propagating the stimulus and eventually affecting a psychological improvement of the depression. So hence it's called the serotonin reuptake inhibitor. No? Now, how do we start treatment with antidepressant medications? One, treat with antidepressants for at least 2 to 4 weeks. Although the first intake should be up in the next few days of intake of an antidepressant, serotonin levels start to normalize, but it takes several days or weeks before these normalization of serotonin levels are converted into actual emotional state of the person. So hence they recommend for observation 2 to 4 weeks. Now in my private clinic, I usually recommend that they do follow up after 2 weeks from when they started treatment. Now, if you're a general practitioner, now you have diagnosed a patient, okay, this patient is suffering from depression, no, because of 5 of the 9 symptoms, 2 weeks, or impaired psychosocial functioning, so you start him with an SSRI, an antidepressant. If after 2 weeks or 2 to 4 weeks they have not improved, then you consider referring that to a psychiatrist. If they have improved with your treatment, then continue treatment for at least 6 months or for the duration of the symptoms, whichever is longer. So that's how you treat that now. I usually tell patients that, we're thinking of more 6 months or more of treatment before we consider stopping the medication. Now, it's very important to know when do you refer to a psychiatrist. Now, primary care physicians should consider referring a patient to a psychiatrist under the following circumstances. Number one, the patient presents a significant suicidal risk. Now, like I said, suicide is an emergency. They have to be handled by professionals. So refer them to a psychiatrist or mental health professional or to the hospital. The second reason to refer a patient to the psychiatrist is that if the patient is pregnant or they have plans to get pregnant and they have symptoms of depression, then it's best to refer to a psychiatrist because of the ramifications of a person being pregnant who gets to become more emotional. And we are also thinking about the postpartum blues or the postpartum depressive disorder. So anyway, there is no evidence. If there is no evidence of social support, no, if a person is depressed and there's just nobody else to take care of this person, then it's better to refer. Now, there are prominent psychosocial issues and interpersonal problems. People who have relationship problems, problems with the family, interpersonal relations, boyfriend, husband, girlfriend, etc., then they're better off being referred because the problem does not resolve so easily. Now, another reason is the patient has certain comorbid conditions. If the patient, for example, is also a substance abuser, or the patient not only has depression but also anxiety or even obsessive compulsive disorder, or worse, patients with dementia. So these are the cases that you need to refer these patients to the psychiatrist. Or even if these things are absent, but you have started treatment and the treatment failed, meaning the symptoms did not remit. Okay, so that ends our discussion on depressive disorders. We now go to the other spectrum, the other end of the spectrum, which is the bipolar disorders. So we start with the bipolar 1 mood disorders, also known as the manic depressives. They are less common than major depressive disorder. In fact, life prevalence is only 1%. So it's just like schizophrenia, 1%. And there is equal male to female ratio of occurrence. Age of onset usually is around 30, but they can happen as early as 5 to 6 years old. They're more common in single and divorced than in people with partners. The incidence is higher among the upper socioeconomic groups, and in people who did not graduate from college. Why is that? Most commonly because it has, as the person goes to college, that is also the time that these symptoms started to appear and they get problems with their academics. Now, bipolar 1 disorder most often starts with depression, right? And is a recurring disorder. That's why it's sometimes these people, bipolar disorder people, are misdiagnosed to be experiencing major depressive disorder because the first symptom usually is that they become depressed. Now, eventually, they develop the manic episode later on. In fact, I have seen one patient who has been uh, having problems academically in college. So he went to my clinic, she went to my clinic, with all the symptoms of depression. And because I diagnosed her with a major depressive disorder, I started I started her on an antidepressant medication. 2 days into treatment, no, 2 days from my clinic, she said, "Doc, the medicine you gave me is so good. I now feel so great, Doc. Thank you very much. You're the best." And then, of course, alarm bells rang in my head. Oops, this is not this is not just an ordinary depression. So I had to inform that patient that she has to stop taking antidepressant medications and to come back in the clinic for a change of medicine. No, because giving antidepressant to a bipolar patient would actually push the patient into the manic pole of the bipolar. No, now, manic episodes have rapid onset, no hours or days, but may evolve over a few weeks. If untreated, manic episodes lasts around 3 months. Now, inter-episode interval is usually 6 to 9 months after 5 episodes. So usually, these are the people you see that sometimes they're so voluble, they talk, have fun, and then suddenly after a few months, they go down into a depressive symptoms and they become silent, they become aloof and withdrawn. These are the usual characteristics of bipolar 1 disorder. Bipolar has a poorer prognosis compared to major depressive disorders. Now, 40 to 50% of patients have a second manic episode within 2 years of the first episode. Now, about 7% of all patients with bipolar disorder do not have recurrence of symptoms. So, only 7% do not have recurrence, meaning they only have one episode. No? So, 45% have more than one episode, and 40% have a chronic disorder. So, you have more or less around 85 to 90% of people who will be suffering this for the rest of their lives. No, only very few, 7%, would have one episode without recurrence. Diagnosis, signs, and symptoms. No? From the data obtained from history, usually they have erratic and disinhibited behavior. No? There is excessive spending, excessive gambling, hypersexuality, even promiscuity. There's also overextended in activities and responsibilities. No, they tend to join so many clubs in college and become leaders in all because they talk well. They have very low frustration tolerance, and there are vegetative signs, so increased libido, weight loss, anorexia, and insomnia. No, insomnia in this case is expressed as, "Doc, I really don't feel like sleeping. An hour of sleep is enough for me. I'm on the go again. I don't need sleep." That's how they look at it. No, it's not like they feel that they're suffering because they cannot sleep. They feel that they don't need to sleep. So there's that excessive energy. Another, the general appearance and behavior, there is usually psychomotor agitation. So there's restlessness. They tend to be seductive and very telling. No, they use colorful clothes and excessive makeup, and there's inattention to personal appearance or bizarre combinations of clothes. No? So they don't actually mind how they look, but usually colored with makeup galore, etc. etc. They have they're intrusive, entertaining, threatening, even hyper excited. And the affect, no, the emotional tone of their face are labile and intense. They may have rapid depressive shifts also. Now, according to their mood, they're usually euphoric, they're expansive, irritable, demanding, and even flirtatious. With their speech, they're usually pressured, loud, dramatic, exaggerated, sometimes even incoherent. No? Thought content, usually highly elevated self-esteem. No? They feel that they are superior, they are bright, and look down on people. They have this grandiosity, they're highly egocentric. No? They feel that they are the most important people. No? They have delusions and less frequently even hallucinations. No? And usually mood congruent themes of inflated self-esteem and self-worth and power, most often grandiose and paranoid. Whether the way they process their thinking, they usually have flight of ideas. Now, if severe, they can even lead to incoherence. Now, they have racing thoughts. No? They usually tell that, paspas kaya ako ang hunahuna dok, dili ka pas akong bakba og istorya. No? They do neologisms also, so they create new words. They do clang associations, circumstantiality, and tangentiality. Their sensorium are usually they're highly distractible. They have difficulty concentrating, and if there's not too distracted, their memory is intact. Abstract thinking is also intact. No, their insight and judgment are usually extremely impaired. No, so they do not recognize that there is something wrong with them. They often there's often a total denial of illness and inability to make any organized or rational decisions. So this is the problem with bipolar people. They feel so bright, they feel so superior, and they don't recognize that they are wrong or that there's something wrong with them. So they tell you there's nothing wrong with me, and then criticize people. So to diagnose DSM-5 criteria for manic episode, because you see, you only need one manic episode to diagnose bipolar. Now, criterion a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased goal directed activity. It has to be goal directed. They want to go to school, they want to be promoted in their jobs, etc. Goal directed activity or energy lasting at least 1 week and present most of the day, nearly every day, or any duration if hospitalization is necessary because of this persistently elevated, expansive, and irritable mood. Criterion B, during the period of mood disturbance and increased energy or activity, 3 or more of the following symptoms, 4 if the mood is only irritable, are present to a significant degree and represent a noticeable change from the usual behavior. So these are the unit 3 or 4. No? Number 1, inflated self-esteem or grandiosity. There's a decreased need for sleep. No? They feel rested after only 3 hours of sleep. They're more talkative than usual, or there's a pressure to keep talking. Number 4, there's flight of ideas or subjective experience that thoughts are racing. There's distractibility, there's an increase in goal-directed activity or psychomotor agitation. And number 7, there's excessive involvement in pleasurable activities that have a high potential for painful consequences. Shopping, gambling, drugs, sex, promiscuity, etc. So criterion C, the mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning, or to necessitate hospitalization to prevent harm to self or others, or there are psychotic features. So very important, no? There has to be a marked impairment in social or occupational functioning, necessitating admission, or if there are psychotic features. No. Criterion D, the episode is not attributable to the physiological effects of a substance, drug of abuse, a medication, or other treatment, or to another medical condition. Note, a full manic episode that emerges during antidepressant treatment, like I said, medication or ECT, but persists at a fully syndromal level beyond the physiological effect of that treatment, is sufficient evidence for a manic episode and therefore a bipolar diagnosis. Like in my patient's case now, even if I stopped the medication, the manic phase continued. So I had to change medications. And what did I change it to? Lithium carbonate. No, the treatment for bipolar 1 disorder is the gold standard is the lithium carbonate, which is effective in 80% of patients. The clinical response to lithium takes about 7 to 10 days. An antipsychotic, like haloperidol or our newer antipsychotic medications, may be added if acute manic symptoms are happening. Starting dose for this lithium is 450 milligrams 2 times a day or at 900 milligrams per day. Lithium blood level of zero point 0.8 to 1.2 milliequivalents per liter is generally necessary to control acute symptoms. So you do that by getting a blood test, no, for lithium levels. Now, the other common treatment for bipolar disorders are your anticonvulsant medications. No? Yes, anticonvulsant medicines are also used as mood stabilizers for bipolar patients. And there are two most common, the valproates, the divalproic sodium, Depakote and Epival, are relatively benign with a very good safety profile. Starting dose is 25 milligram per kilograms daily, as a single dose. Now, another drug is carbamazepine, your Tegretol, which you use for patients with seizure problems. So we give that 200 milligrams either BID or TID. No? However, there are common dose-related adverse effects like sedation, nausea, blurred vision, ataxia, and the worst is the Stevens-Johnson syndrome. No? That's why carbamazepine is not a very popular drug, although it's a very effective drug, but because of this, albeit rare side effect, Stevens-Johnson syndrome, where you'd have bullae of your skin, so they're not even used often nowadays. So another disorder is the bipolar 2 disorder. Now, in this particular disorder, the patient has had at least one major depressive episode and at least one hypomanic episode. Remember, it's not manic episode, this is hypomanic. So pag manic episode, it is bipolar 1. Pag hypomanic episode combined with a major depressive episode, then it is a bipolar 2 disorder. So to diagnose the DSM-5 criteria for hypomanic episode, criterion a distinct period of abnormally and persistently elevated, expansive or irritable mood, and abnormally and persistently increased activity or energy, lasting at least 4 consecutive days and present most of the day, nearly every day. Now, you will notice now the criterion A of manic episode and criterion A of hypomanic episode are almost the same, except for that, no, lasting at least 4 consecutive days sa hypomanic episode. Now, during the period of mood disturbance and increased energy and activity, 3 or more of the following, they're actually the same as with our bipolar 1 manic symptoms, 1 to 7, they're all the same. No? So criterion C, the episode is associated with an unequivocal change in functioning that is uncharacteristic of the person when not symptomatic. Now, remember, if you remember the criterion C also for manic episode, it's not just an unequivocal change. No? It says there is an obvious impairment in functioning. But sa hypomanic, dili lang, naalay change, no? Which is uncharacteristic for the person when not symptomatic. Criterion D, the disturbance in mood and the change in character is observable by others. No? Criterion E, the episode is not severe enough to cause marked impairment in social or occupational functioning, or even to necessitate hospitalization. So there is an obvious change observable by others, but not necessitating admission or not necessarily impairing the person's capacity to work. You know. Now, if there are psychotic features, the episode is by definition manic So even if functional siya pero psychotic siya, paranoid, then you say this is not hypomanic anymore. Pag naanay psychotic symptoms, it becomes manic episode. Therefore, you diagnose that person as bipolar 1. No? So remember, pag bipolar 2, wala pa'y psychotic symptoms. Letter F, criterion F, the episode is not attributable to the physiological effects of a substance, like for example, drugs of abuse, a medication, or other treatment options. Another disorder is called cyclothymic disorder, which is a chronic fluctuating disturbance with many periods of hypomania and of depression. Symptomatically a mild form of bipolar 2 disorder. No, so bipolar 1, milder sa bipolar 1, bipolar 2, and milder sa bipolar 2 is cyclothymic disorder. But remember, from the term alone in the name, it is a fluctuating disturbance with many periods, no? So several periods of hypomania and depression coming together. There's symptomatically mild, lifetime prevalence is also like schizophrenia, 1%, but it is more common in women than in men. Now, 30% have family history of bipolar 1 disorder. So what happens in cyclothymic disorder? According to Freud, the cyclothymic state is the ego's attempt to overcome a harsh and punitive superego. Remember, superego are your conscience. Now, if your conscience is so strong, then you might go into a hypomanic episode. No? Hypomania results to the lack of self-criticism and an absence of inhibitions occurring when a depressed person throws off the burden of overly harsh superego. So this is a defense against your overly harsh superego. So since harsh is superego, you develop this hypomanic state. I'm better than anyone else, like that. Okay, now psychoanalytic exploration reveals that such patients defend themselves against underlying depressive themes with their euphoric or hypomanic episode. It's more like a defense, no more reaction formation. I'm sad and then I will become happy, because of all these sadness that I feel. So it's a defense mechanism. Hypomania is frequently triggered by profound loss. No? The false euphoria generated in such instances is the patient's way to deny dependence on love objects while simultaneously disavowing any aggression or destructiveness that may have contributed to the loss of the loved person. Now, hypomania is also associated with an unconscious fantasy that the lost object has been restored. Now, this denial is generally short-lived, and the patient soon resumes the preoccupation with suffering and misery characteristic of a dysthymic disorder. Remember, dysthymic disorder is the chronic form of depression. Now, cyclothymia is the chronic form of bipolar. No? Now, to diagnose criteria for cyclothymic disorder, criterion A, for at least 2 years, just like in dysthymia, 2 year or the persistent depressive disorder, no? For at least 2 years or at least 1 year in children and adolescents, there have been numerous periods with hypomanic symptoms that do not meet criteria for hypomanic episode and numerous periods with depressive symptoms that do not meet the criteria for a major depressive episode. So very tricky, guys, no? Because it says here na ay symptoms for hypomania but they do not meet the hypomanic criteria. Na symptoms of depression but they do not meet the major depressive episode symptom also. So naay gamay lang siya nga mania, nga hypomania, naay gamay nga depression. 2 years, no? Now, criterion B, during the above 2 year period or 1 year in children and adolescents, the hypomanic and depressive periods have been present for at least half the time and the individual has not been without the symptoms for more than 2 months at a time. So in the span of 2 years, pwede siya ma-okay less than a month or less than 2 months, but dapat dili beyond that. Kung beyond that, then probably you're diagnosing that person with either bipolar 2 disorder, not cyclothymia, no? Kung beyond na siya sa 2 year. sa 2 months nga symptom-free siya. Okay, criterion C, the criteria for major depressive disorder, manic or hypomanic episode have never been met. Again, no, sa cyclothymia, naa siya hypomania, naa siya depression, naa siya hypomania or manic episode but do not meet the criteria either in duration or in the symptoms. Now, criterion D, the symptoms in criterion A are not better explained by your schizoaffective, your schizophrenia, your schizophreniform, your delusional disorder, or other specified or unspecified schizophrenia spectrum, or other psychotic disorder. Criterion E, the symptoms are not attributable to the physiological effects of the substance or another medical condition. You will always see this na kanina criteria nga dapat dili siya influenced by drugs or illness or medicine. Criterion F, the symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And lastly, the course of cyclothymic disorder. The patients with cyclothymic disorder were usually sensitive, hyperactive, or moody when they were children. The onset of frank symptoms occurs insidiously, meaning slowly, during their teens or early 20s. About one-third develop a major mood disorder, usually bipolar 2 disorder. Treatment, no, there are several. The gold standard, of course, lithium, carbamazepine, or valproate. No, antidepressant treatment should be done with caution, as this would cause antidepressant-induced hypomanic or manic episodes. So again, let us be careful in not giving antidepressants for people who probably you suspect of being hypomanic or manic. Now, last slide, psychosocial factors. Psychotherapy is directed toward the increasing patients' awareness of their condition and helping them develop coping mechanisms for their mood swings. Remember, the symptom of bipolar is actually a coping mechanism. No? Patients often require lifelong treatment because of the long-term nature of the disorder. That ends our lecture for today. Have a nice day, guys.